press that blue button. Good afternoon and welcome. My name is Nilanjan Sarkar and I am Deputy Director of the South Asia Centre here at the London School of Economics. Welcome to the first event in our new autumn academic term. I'm very, very happy to welcome all of you to this event, as also our speakers who are joining us from different parts of the world. And we're all looking forward to their expertise with regards to the event this afternoon. The event is titled South Asia Paternalism and Public Health Care, which is, of course, a very broad, wide-angled topic and theme to give, but it is also a very, very important theme, simply because it is so strongly culturally coded in societies in South Asia, and yet also has a very direct and very tangible impact on public health care, and especially with regards to women, to medical practice, to patient and public interactions, doctor-patient communications, I beg your pardon, and dynamics, medical decision-making, as well as the way in which doctors conduct themselves in relation to patients. And part of the discussion, I hope, this afternoon will also be on how South Asia can move towards a more patient-centered healthcare approach in different countries. We have speakers from Sri Lanka, from Pakistan, and from India. And I'm very much looking forward to what we're going to hear as well as learn. I'm not going to say too much more. This is not my expertise. And before I introduce the panelists, I do want to say a very warm welcome to members of the audience who are joining us from different parts of the world across different time zones, for which I'm always very grateful. We have a very loyal audience, and thank you very much for your interest in our event. This event is happening via Zoom and is being live streamed on YouTube, as you can see, because all of you are watching it on YouTube. And you will see that the chat function is enabled. And please ask your questions over there. And I will pose questions to the speakers at irregular intervals once the questions start coming in. As members of the audience, please know that had this event been happening on site at LSE, audience members have the right to ask questions without revealing their identity. And in keeping close to the spirit of that, when I pose the questions, I will not be announcing your names. You are welcome to ask a question to an individual panelist. You're equally welcome to ask a question to the entire panel. Just mention it when you write your question, and I will pose it accordingly. It is now my very pleasant task to introduce the speakers. Our first speaker is Dr. Aisha Jalil. Aisha was the Charles Wallace Pakistan Trust Visiting Fellow at the LSE South Asia Centre earlier this year, from January to April. And the central theme of today's discussion is part of her research interests. She trained as a sociologist. Her doctoral research and publications have focused on patient satisfaction in public clinics in Pakistan, in Lahore in particular. She's currently Deputy Director of International Strategies and Partnerships at the National University of Sciences and Technology in Islamabad. Indika Karunathilake is Professor and Head the Department of Medical Education at the University of Colombo, and has worked extensively. And I have to say this very, very clearly. His publications, if you look at the website, are both in English as well as in Sinhala on public health practices in contemporary Sri Lanka. This is not something that we come across easily amongst academics who, I dare say, at least the ones I interact with, tend to prefer to publish only in English. Deen Dayal Reddy is Professor Emeritus of Biomedical Ethics, a retired professional with over 4 decades of experience in clinical research in biopharma and research ethics. He's currently affiliated with the Ethics Committee at St. Joseph Medical Center in Bellingham in Washington in the United States. The discussant for this afternoon's event is Dr. Rishita Nandagiri, who is lecturer in global health and global medicine at King's College London and visiting fellow in the Department of International Development here at the London School of Economics. Rishita's interdisciplinary research on abortion practices in India is underpinned by feminist and reproductive justice approaches, interrogating how power and politics manifest and are wielded at individual, interpersonal, community, and macro levels. Everyone, welcome to this afternoon's event. I'm now going to invite Aisha to speak first. Aisha will speak for about 10 minutes, speak not only about her own research and her own ideas about this theme, but also laying out the broader contours within which this afternoon's event is going to happen. Aisha, please speak now.
Hi, everyone. Thank you so much, Dr. Nilanjan, for giving me this opportunity to speak about my research on paternalism in the medical practice and in the context of Pakistan especially. I'm absolutely thrilled to be part of this panel today, and I'm honored to be interacting and listening to the worthy panelists. So before we begin the discussion, let me define paternalism in medical practice. According to the empirical literature, medical paternalism is a physician-focused model of healthcare provision in which the doctor assumes a superior position as compared to the patient, of course, based on his or her competency in the field and years of medical practice. So, of course, with a good intention, doctor has an authority to make decisions on behalf of the patient according to this approach. This generates some ethical concerns about the patient's autonomy, informed consent, information disclosure about the illness, and trust in the patient, and of course, the respect of the patient sometimes. So this approach is found to be effective in the context of Pakistan because majority of the patient in the poor resource hospitals, like the public hospitals, which are free, the patient is mainly the poor and the uneducated. And it is assumed that it is the perceived duty of the doctor to act in patient's best interest, and the patients have absolutely no issue if the doctor is verbally abusing them or is rude to them, because patients have the trust in the doctor and they think that the doctor is superior because of his expertise in the field. So there are some key points that we will be focusing in today's discussion. Firstly, we will take a look at, is paternalism being practiced in South Asian countries like in Pakistan, India, Sri Lanka, and Bangladesh? And is medical paternalism a more suitable approach to healthcare in South Asian context as compared to the patient-centered care approach? And secondly, what role do cultural and societal norms play in medical paternalism? Do cultural attitudes towards the authority figures, such as the doctors or the fathers in the family, influence perceptions of paternalism? How does it vary in the region, like in the countries of the region? Pakistan, India, Sri Lanka, and Bangladesh. So third question would be, does paternalism benefit or harm patients' trust in the doctor? How to address the ethical dilemmas associated with the paternalism. And finally, how do the gender and social class relate to the paternalism, and in what ways might the doctor disproportionately exercise paternalism towards women or the individuals from less privileged segments of the society? So let's begin the discussion. I would like to share some of the key findings of my research at this point. So due to the social hierarchies, low health literacy, poverty, and the scarcity of healthcare resources, paternalism is found to be a suitable approach to healthcare provision in Pakistani context. However, it is coexisting in the presence of factors that affect the conduct, competence, and sometimes the professionalism of the doctors. For example, the rudeness towards the patient leads to fear and reluctance among the patients to ask questions. And whenever there are situations in which there isn't much clarity for the patient about the disease management plan, it becomes difficult for the patient to ask questions from a rude doctor. Um, there is also a common perception among public hospital patients that God forbid the doctors, the young doctors, especially the house officers who are like in the first year of their internship, and they have recently completed their medical education, and they are now in the hospital, in a public hospital, and they are learning by experimenting on the poor patient, which is quite unfortunate. It is believed in the society that they are experimenting with the patients, poor patients. So regarding the trust on the doctor, the findings of my research actually reveal that patients trust more on the strict and angry doctor. This is specifically about the patients who are coming from poor socioeconomic background, and especially the women in the public hospitals who actually trust more on a strict and angry doctor. Poor patients, like in public hospitals, do not mind being verbally abused, as I've told you earlier, as they perceive that the doctor wants them to recover from the illness, and that is why the doctor is asking them strictly to follow the disease management plan. So in contrast, there is another category of patient which is coming from the middle and the elite class background, and they can afford the hospitalization and medical care in the private hospitals, the fee-for-service clinics. So they are more aware of their rights and want to be treated with respect, and their healthcare preference is more related to the patient-centered healthcare approach. So, and they want to be informed about the illness and the treatment plan and the options before they opt for something mutually. And in this patient-centered care approach, basically the patient as well as the doctor are treated as the equal members of the team. There is a need for more research, I think, on whether it is the paternalism responsible for the behavioral problems of the doctors in the public hospitals, or there are some certain other factors, because there is a general problem in the communication and interpersonal skills of the doctors in Pakistan. Like patients have reported behavior such as ridiculing of the patients and like not answering or explaining, which is of course contrary to the Hippocratic oath, which has the primary guideline to do not harm the patient and use the knowledge for the favor of, in favor of, and in the best interest of the patient. So about the undisclosure of information, I found very interesting and unusual facts. Female patient in my field research actually revealed her satisfaction with the information about the information that was undisclosed by her surgeon. She had a brain tumor, and she actually thought that the doctor didn't tell her about her illness and called her for a surgery. And once she was recovered from that illness and was back to a normal life, the doctor told her that now she's fine, and she had a brain tumor and the doctor operated her. So she was very thankful to the doctor. And in these circumstances, I think the paternalism works well when the patient has less knowledge about the disease management, and they think that the doctor is taking right decision for the treatment of their illness. So the problem may arise when the doctor withholds some information, and the outcome of that treatment is negative or it is ineffective, maybe. This circumstance might affect the trust of the patient a patient may experience side effects or a diminished quality of life from a treatment they would not have chosen if they had been fully informed. So it is assumed that these actions are well intended by the doctor, but these situations might raise some ethical concerns which are serious. So I collected data from doctors as well as the patients in both of my researches, which is like published in BMC Health Services Research. And my research findings basically implied prevalence of paternalism in the public healthcare sector. There are two categories of patients, as I told you. One is the affordable class, and the other one is underprivileged class. I found greater acceptance of paternalism among the female patients and the poor patients. And that's all from my side for now.
Okay, thank you very much, Aisha, for setting out the basics and the broad contours. Professor Reddy, we have you up next, and just to reintroduce you for those who have joined us since I did the first set of introductions, Deendayal Reddy is Professor Emeritus of Biomedical Ethics, is a retired professional with over 4 decades of experience in clinical research and research ethics. He's currently affiliated with the Ethics Committee at St. Joseph Medical Center, which is in Bellingham in Washington. Professor Reddy, please speak now. You have about 6 to 8 minutes.
Greetings from United States. And I should also say adab, namaste, sat sri akal, vanakkam, and of course, a happy Wednesday to you all. For the invitation and for the opportunity to share this dais with so many scholars and scholarly participants, I wish to thank Dr. Nilanjan Sarkar and the London School of Economics. Before sharing my 2 or 3 points on the reasons for the state of affairs vis-a-vis doctor-patient relationship based on a paternalistic model that is much so prevalent, even in India. Also, I want us to consider the words of Plato. In his Republic, book number 8, he notes, what is honored in a society is cultivated there. If we honor our women in the house, you would see that in the streets as well. Based on Plato's assessment and India's own healthcare indicators, including international assessment of Indian state of affairs, especially vis-a-vis healthcare accessibility, the World Health Organization numbers, the European Center for Population numbers, the Transparency International numbers, and my own experience as a professor teaching bioethics in Indian colleges, I can say that India scores low marks on access to medical care, low marks on the quality of medical education, low marks on self-governance. And obviously, the doctor-patient relationships, we do not take it as an isolated instance. It doesn't operate in a vacuum. All these contributing factors, such as what Dr. Nilanjan Sarkar mentioned, they are culturally coded. So it is not a really surprise. Once you come out of the house, you're finding the same stuff. So my point is, this is the point number 1, which is somehow all these things came together. The quality of medical education, the quality of medical care, the accessibility of medical care, and the environment that we have created, the culturally coded messages we are giving day in and day out, they are contributing to breeding an ecology or an environment that is not conducive to ethical behavior, let alone doctor-patient relationship. This is point number 1. Now, look, it's easy to criticize India, especially from abroad. And my colleagues would, if they hear me, or my friends would say, you want to say anything to me, say it to my face. But I am not trying to put down India. I am from there. I would like us to do better than what we have been doing. And one of the things I've learned in my life and in the life of other countries, so to speak, is that 150 years ago, the countries I'm citing are, for example, Australia, Canada, Denmark, New Zealand, United Kingdom, and United States. 150 years ago, their fate was worse than that of India. They violated human rights, voting rights, and civil rights just about 150 years ago. But now they have been regarded by the same European Center for Population Studies, by the same WHO numbers, and the Transparency International that monitors corruption and honesty and ethical behavior, the countries around the world. These 6 countries have come up on the top of the list. So my point is that they have been doing something right. And if they've been doing something right, we too can emulate that manner if it is applicable to our situations. And I believe it is. But what they have done, one of the reasons, by the way, the countries that I've just named, they're called as a full-fledged democracies. And India has been named, and countries like India and others, we are fledgling democracies. We are faulty democracies because we are still struggling. Healthcare is not available to everyone equally. And there is a post-colonial era, the weight of the colonial era top-down approach. There is bureaucracy, which is one of the worst in Asia. And we all know that absolute bureaucracy corrupts, absolutely. But we can get out of this if we follow the manner what they have done. One of the things we could emulate is that one of the secrets of the countries that I've just mentioned, like Australia, Canada, Denmark, New Zealand, UK, and USA, they have created a political culture conducive to ethical behavior, thriving democratic principles. There is a valid system of governmental checks and balances. More importantly, there is an independent judiciary whose decisions are enforced. And there is a presence of independent media that serves as a watchdog for the activities of the government. Basically, decentralization of the government. They have been following the privatization of capital and the free market economy that ends up helping more people at a given time. And that is one of the reasons. Let's take United States. Up until 1964, US also should have been called, it was called as a fledgling democracy because democratic rights were not given to all the people. Within 50 years, and now everybody from every other country would like to come down here. So that the democracy works, secularism works, and another one of the great points I would like to, I give them credit for these countries is that all the bioethics literature that we are studying, the bioethics regulations on human rights, they have emanated from Australia, Canada, Denmark, New Zealand, United Kingdom, and United States. The second point is, which I've already mentioned, if these countries can change on a dime, granted they've taken about 75 years, and it has been only 75 years since our independence from the British Raj. Perhaps it will take another 75 years. Can we change the constitution sitting here in this conference? Obviously not. Can we remove the bureaucracy overnight? And obviously not. Can we take what is coded in our culture, what is being coded in our genes, as it were? Can we remove it? I don't believe we have a scrub sufficient enough to remove the lineage, the molecular lineage that still sticks to us. But I believe, I'm very confident, this is point number 3, that we can do is improve the quality of education. Here, I'd like to take a few seconds. The medical students in India, basically high school graduates are allowed to get into medical school without the benefit of reading humanities, without the benefit of studying ethics or psychology or communication or sociology, anthropology, these humanities or liberal arts that gives them a well-rounded look to understand how democracy works and how the role of a physician when dealing with the patients, especially the marginalized, especially the women, the disenfranchised, and the aged, and for whom healthcare resources are not available, they don't really have a voice when speaking to a doctor. So we need a compassionate doctor who understands what it is to be a physician, what it is to help other people to start with. So if we can start off with humanities, social sciences, civics, and the duties of good citizenship, it is possible that a well-educated electorate, they can begin a conversation at the grassroots level. Instead of changes coming from the top down, we can usher changes from the grassroots from bottom up so that the government would be more responsible for the needs of the patients, the women, the vulnerable, the aged, and those who need the help most.
Sure. Thank you very much, Professor Reddy, for laying all those out, not least the very interesting point that those who are entering medical education after high school should be trained in humanities and social sciences, which doesn't happen in many parts of South Asia and other parts of the world as well. Our next speaker is Indika Karunathilake, who is currently professor and head of the Department of Medical Education at the University of Colombo. And Indika has worked extensively and published in English and Sinhala on public health practices in contemporary Sri Lanka. Indika, please speak now. You have about 6 to 8 minutes.
Yeah, thank you, Dr. Nilanjan, for the very kind introduction and greetings from Sri Lanka. So I'll be discussing based on my experience in work in Sri Lanka. And at the very outset, I would like to say it would be a little different based on the context, little different from what we have heard from the other experts before, due to many reasons. One is Sri Lanka has a very strong tradition in health and education. The health system is entirely free, even though there's a private sector, and the universal access to healthcare is there. And also, very importantly, the free education system, which has been there since, I think, 1950s. So in that way, the school enrollment is more than 90% for the children. And the most important factor that I would like to highlight is a high female literacy rate. And it is over 92% in Sri Lanka, and among the highest, by some distance, the highest in Southeast Asia, and very much comparable with other developed countries, more developed countries in the Asian region, which is more than 92%. And if you take the other public health indicators also, you might have heard about the case studies in Sri Lanka. They are very much comparable with countries with high income. If you take maybe the literacy rate or maybe the immunization into 90s, and also the mortality rates, the infant mortality, maternal mortality rates, all these figures, when you really compare, they are very much comparable with high income countries, even though Sri Lanka is a low middle income country. And so one big reason is the free healthcare system that I have mentioned, and the access to healthcare also, where you can access the healthcare system within few kilometers. So in that way, there are many positives, especially the immunization, because from the beginning, the country has been focusing the limited resources on few specific areas like sanitation, nutrition, immunization, and also education. And if someone asks what would be the single most important determining factor, what I would say is the female education, because that has far-reaching implications, not only the literacy rate, but it has led to increased health-seeking behavior and also high health literacy. and therefore access to healthcare and more seeking out healthcare very actively. And therefore, in Sri Lankan society, the female or the woman has become the leading person when it comes to deciding the health-seeking patterns, behaviors, so on and so forth. So that's a very important and a very unique factor. And thirdly, like many other South Asian countries, ours is also, the culture is based on the religion and the South Asian culture. Sri Lanka is predominantly a Buddhist country with the main language being Sinhalese, and there is Hinduism and also Tamil being spoken, and similarly there is a considerable Muslim population as well, and Christianity as also. Culturally, it has been very traditional. I mean, if you compare, very similar to all the other South Asian countries, very traditional. So when it comes to certain health issues, for example, especially the sexual health issues, there has to be some reluctance when compared to other areas. There has been some reluctance in coming forward or in the health-seeking behavior. Again, getting back to the health system, so one fact, as I have mentioned, is the high literacy rate. And similarly, since we have a very extensive public health network at the grassroots level, where we have whom we call the public health midwife, who go from home to home in the villages and the cities, and then meet the eligible couples and get their details even before they get pregnant. So the ladies get pregnant, and giving all the advices, family planning, all these things are given at the very outset. And they give the education to the ladies, when to seek healthcare, when to go to the clinic, and so that is there even from the childhood. For example, the rubella immunization has been very active. So the health-seeking behavior is ingrained into the Sri Lankan ladies because of that, because of the high literacy rate, and also because of the health system. Because of the health system, they are compelled to maybe facilitated to go to the hospitals when they get pregnant, and most of the deliveries, almost 99%, are institutional deliveries. So they have to go to the hospitals and go to the clinics. In that way, automatically their health status get checked. So actually, in that way, the Sri Lankan females have higher advantage compared to males. Much higher advantage, because males would not go to hospital unless you really feel not well, or unless you are having some symptoms. They might not go to the hospitals unless you go through some screening programs. But because of the health system, Sri Lankan ladies, it's mandatory that they have to go through this health system, they have to go through the screening, so their blood pressure gets checked, blood sugar gets checked, the most important parameters are get tested. So that's an advantage. So because of all these things, the health-seeking behavior among the Sri Lankan females is very high. And also, like other South Asian countries, it's basically a patriarchal society in Sri Lanka, but at the same time, the mother plays a big role in the home front. Even though the father is considered as the sole breadwinner, and then financially he's the person who brings the money usually, but that's also changing with the education. Mother is the person who looks after children and look after welfare of the house. Basically, the home front is managed by the mother. And because of the high education, that is facilitated even better. So decisions regarding the health and the nutrition, those decisions are taken by the mother. So that's also another big plus factor. And also when it comes to medical education, the medical education in Sri Lanka, it's a very much tightly regulated, because we have a very highly regulated system with only 11 medical schools, and our intake is about 1,500 students per year. And our curricula have changed some time ago. About 20 years ago, we have moved towards more problem-based, more integrated, the SPICES model, and more community-oriented model. And there's a lot of focus on communication skills and the professionalism. So in that way, the doctors are trained in better communication and professionalism, ethics, so on and so forth. And currently, another interesting phenomena is majority of our health workers are actually females. So if you take all these things together, what we see is actually females are playing a huge role when it comes to health-seeking behavior and health. Having said that, I'm not telling that everything is perfect. I mean, there are a lot of areas that needs improvement. Still, our society or even our health system is very hierarchical, and there may be some barriers when it comes to communication. So those issues are there. And also, especially when it comes to sexual health issues and areas like, say, abortion, there are huge problems. So because of that, there can be some illegal practices coming up and unhealthy practices coming up. So one big problem I see is the lack of openness related to the sexual health issues. That may be partly due to the inhibition that is due to the culture. That's very possible, because still the females are very much reluctant to discuss about sexual health issues openly. So that can be one area. So there are areas for improvement as well. But I think compared to many countries in the South Asian region, Sri Lanka has advanced a lot, mainly due to the high literacy rate of the females. Thank you. Okay.
Thank you very much. Thank you very much, Indika. That was very useful to know. And I'm sure we'll come back to some of the things that you have mentioned in terms of questions, which gives me the chance to say also to members of the audience, please, if you would like to ask any questions, please do type them in the chat box and I will post them at regular intervals. But in the meantime, I'm delighted to introduce our discussant, Dr. Rishita Nandagiri, who is currently lecturer in global health and global medicine at King's College London. Rishita is also visiting fellow in the Department of International Development here at the London School of Economics. Her interdisciplinary research on abortion practices in India is underpinned by feminist and reproductive justice approaches, interrogating how power and politics manifest and are wielded at individual, interpersonal, community, and macro levels. So fits in perfectly with the broader themes of this afternoon's discussion. And I have to say that the end of Indika's talk is a very good segue into what you are going to, I'm sure, going to touch upon. So please go ahead, Rishita. Rishita will present her own views initially, and then as discussant, we can begin the discussion. Thank you.
Thank you so much. And thank you, Nilanjan, for Dr. Sarkar for inviting me, and to all of our excellent panelists. It's so much to think about. So much have resonated with my own work. Actually, something that Professor Reddy said really struck me when he was talking about how these things don't occur in a vacuum. These are political, cultural, these are shaped by our societies. And one of the things that I think is really important for us to think about when we're talking about medical paternalism is that that doesn't just happen in the clinic. That doesn't just happen in your interaction between the physician and the patient. These are things that are coded into our laws. So in a lot of my work, actually, as Professor Karunathilake was also talking about, how we think about, say, abortion rights and how we think about abortion laws. Now, most abortion laws require the judgment of the physician, require permission from the physician. This is true in India, where you require one doctor up to 20 weeks, two doctors between 20 to 24 weeks. You need their permission. There is a whole idea around in good faith. Now, these were similar things that were being discussed in Sri Lanka recently, and my colleague Sachini Pereira, who works in that context, was also discussing how these laws still hold medical authority, medical knowledge at the center of it. And it's tied to then how we think about these issues, right? How we think about abortion, how we think about sexual health as fundamentally questions of public health. But these are also questions of people's rights, people's autonomies, and how they understand and negotiate these spaces. And when we are, again, as Professor Reddy was pointing to, when we are in spaces that are patriarchal, that are tied to certain gender norms, like even this idea of the valorization of motherhood, can have really constraining effects on whether people are able to access abortion, the conditions under which they access it, even contraception. So thinking about my own research in India, where I interviewed and I worked with women who had abortions in rural districts in India, in South India in particular, and a lot of them self-managed their abortions. So we are seeing in India, even though the law is quite liberal, in theory, you should be able to access an abortion through a public healthcare center where it should be free. 80% of abortions in India are medical abortions that occur completely outside of healthcare systems. And a lot of the women talked about being stigmatized. They talked about how they had been spoken to when they were giving birth, that they were treated disrespectfully, that they were treated violently, that they were told, you need to be sterilized. You've had 2 children now, be sterilized. These weren't things that they wanted to do. They stop engaging with a healthcare system, particularly when you're treated in ways that that they feel they're not able to access or to access care in the ways that they need to access care. One of the things, if any of you have been paying attention this week, that came up is there is a proposal by the Central Drug Standard Control of India for a recommendation that's going to come out shortly to ban access to emergency contraception over the counter. So up until now, you could go into a pharmacy and ask for it without a prescription. Now the recommendation that they suggest is that you require a prescription. Now, this plays out in extremely gendered ways. So once again, coming back to this idea of that this is not a vacuum, we need to consider how medical paternalism, because if you need a prescription for something that is deeply time-bound, in a context where we do not have enough doctors, where getting an appointment is very, very difficult, and then needing to go to a clinic and find a pharmacy where you can fill your prescription in a way that you don't feel stigmatized once again, right? All of these things need to line up for you in order to access what is baseline care. Now, a lot of the concerns around this have come from doctors, have come from physicians to say, oh, there is a misuse of this, of using too many hormonal contraceptions. Now, first, we have no evidence of this misuse, right? Second, these fears around what impact this has on people's health, on particularly women's health. But a lot of what they have pointed to are not side effects of nausea, headaches, and so on. Those are effects. That is what the effect of this medicine as part of it. What happens with this is that emergency contraception here is not about emergency contraception itself, but it functions as a form of moral panic. There's too many people having sex, in essence. So in this, and we need to control that, and the way to control that is through medicine. It's through doctors. And so to remove this understanding of how sexual norms, how fertility norms play out within and through the clinic is also to overlook how people are engaging with this and finding ways to resist. And that's why you can see, for example, why we're having so many medical abortions outside the healthcare system, right? That's because you would rather not engage. And I think this brings me really to something that I think both Professor Karunathilake and Dr. Jalil were saying, is to consider, what does it mean to care? What does it mean to offer care for people who are seeking care? It's not just this relationship of who holds knowledge and whether that knowledge is transmitted or not, or whether you have health seeking or you have health literacy. It's also about the conditions in which we are considering how people are accessing care, whether that care meets their needs. Now, even in a lot of my interviews, very similar to Dr. Jalil, people were grateful. They were grateful for whatever care that they could get from the healthcare system. And it pushes me to ask, is that the best that we can offer? You received care. You were verbally abused. There were things that, there were procedures conducted upon you that you fully weren't aware of. And lucky, the outcomes were not bad. So when we are discussing questions of medical paternalism, it's functioning across multiple levels, not just in whether our outcomes are good or not, but in how have we conceptualized how we are delivering care and how care is being received. Whether that has long-term consequences beyond these notions of trust, like, yes, as we've seen with the pandemic, right? How people's healthcare and health-seeking behavior has been shaped by mistrust or distrust, whether earned or not, in the healthcare system. And we see this very much in India and in Pakistan, in Sri Lanka, and in Bangladesh. And again, coming back to what Professor Reddy was saying around this erosion of political institutions. And if so in this space of how we think of medical paternalism, I keep coming back to this idea that our notions of health within the WHO are that it is more than a medical matter, right? It is not just the absence of disease. It is something positive. It's for the flourishing of your well-being. So if we start to unpick what does a flourishing of well-being mean, or what does this flourishing of your health mean, then we keep coming up against this idea of paternalism and what role it plays. And yeah, so I guess one of the questions I'd like to kick us off with is what then, and tying back to what Nilanjan actually urged us to do, what's a way forward? And I guess one way that I think might be quite generative is to ask, what does care look like? What does care look like, whether in the context of medical paternalism that may or may not produce gratitude? And what does care look like that may be more rights affirming, that may be more justice oriented, that may require some of these checks and balances in place as well? Thanks.
Yes, great. Thank you very much, Rishta. That was wonderful. How should we do this? Aisha, would you like to speak first? And then maybe Indika can speak and Dean can come in. I mean, Aisha, would you like to go first?
Yeah, sure. Actually, I really like the ideas of our panelists, and it was very interesting, and some new information is being shared for me in the context of Sri Lanka, India. And yes, I wanted to say a few things. I agree with the respected Professor Reddy about the unequal distribution of power, which is leading to interpersonal problems. And also, he said that the environment is not conducive to ethical practice for the doctors. So I have a question for Professor Reddy at this point, that is it paternalism that is affecting the environment, or there are some other factors which are like affecting the conduct of the doctors, or what exactly are the factors in the environment which is like hindering the ethical medical practice in the context of India?
Awesome. Thank you. If I may, Dr. Sarkar, may I respond?
Yes, on the condition that you turn on your camera.
I thought I did. No?
No.
I'm so sorry.
Yeah,
I'm so sorry.
That's great. Yeah, go.
Awesome. Dr. Aisha, thank you for asking the question. To the modesty of my understanding, let me give an analogy, with regard to an environment that conduces, that forces us to take the shortcuts as opposed to a systematic study, systematic investigation. I was thinking about Taj Mahal. Recently, I was reading about it. There are cracks in the minarets. A quick fix thing is we would say, like, slap some cement and then talk about it later, because it is efficient. Somebody's coming over, the prime minister is coming over. We need to make it look pretty, so we'll just do that and then forget about it. What we need to do is go to the foundational problem. And to see the foundational problem, we need to consult the experts who know how good at it. And also realize this is going to be a long haul. Change is so difficult. Usually, and another thing, Dr. Aisha, is that education does not automatically make us virtuous. Just because we are living in an environment that is conducive to ethical behavior doesn't motivate us to go there and do the right thing. As you know, the old adage, you can take the horse to the water, but you can't make it drink. And here Aristotle comes and helps us. We have to have an internal motivation that, this is part of the equation. We are part of the whole structure. Another quick analogy, without taking too much time, take, for instance, India. India has done considerably well since independence. For the 75 years, there are more people in India. There's more money in India. There are more doctors in India, more hospitals in India, more cars in India, more corruption in India, more traffic jam in India. Let's say traffic jam. And how do we fix the traffic jam? This traffic jam is making us, for example, there is a virtuous person driving a car on the streets of India. He needs to go from point A to point B. there is no way he can get to the destination without violating some traffic laws, if not the common canons of decency. So the traffic itself, we are using the same old roads and we are putting 116,000 cars on it. And we are saying, now let's behave ethically. And the same Indians, who come to United States, we have the lowest rate of incarceration in the American courts because, there is an environment that encourages us. And another thought is that, if you break these laws, there are penalties which are severe and we are immediate. So whether I'm a virtuous person, physician or not, the fear of losing my license would motivate me to not to mess around. And a behavior like this over time, I should like to believe some of it would rub off on us. Our generation, will keep on talking about it. And hopefully some of it would rub off on us and our children, the way we treat them, and the way we treat our own women in our own house. And then second, third generation, maybe Indians too, once they're educated. Educated people means taking ownership in the government. And one more last thing. In America, we never, I've been living here nearly 50 years. I never use the word government. We have nothing to do with the government except renew my passport when it is expired. The driver's license is also managed by a private enterprise now. Back home in India, everything that you do, the kerosene you want to buy, you need to know somebody. You want to buy a car, you need to know somebody. I mean, it is so frustrating. So even if you want to do the right thing, it is frustrating. So there is no incentive. So I hope I answered it in a roundabout way.
Can I just come in? Indika, I'm going to ask you to respond. But just before that, Aisha, you do need to answer the question that Rishita posed about what the way ahead looks like. But we will come back to you once we've sort of gone around the table, as it were. Professor Reddy, one of the things you said, which struck me in a very interesting sort of way, because I came out of high school in the 1980s, and I studied humanities. Those who went on to study medicine, because of the way in which the discipline itself is understood as one of scientificity and science, that you need to have biology in your high school in order to understand. My question to you is, given that admission structure, because of other things you said, is unlikely to change anytime soon.
Correct.
Do you think that it would be more useful to consider, as some more recent liberal arts universities have done, focusing on things like management, business management and all, is that once they get into medical school, these students should be asked to study the humanities, the arts and humanities, in order to sensitize them and to make them more empathetic, rather than have a merely clinical approach to the entire engagement with being trained as a doctor. Do you think it should be introduced at that level, or do you think they should be introduced to it at high school when they are preparing to give the exam? That it's the stage that I'm trying to figure out from you, what your view is on the matter. Because you did also say that this suggestion sits alongside a variety of other problems, including the fact that there is a lot of bureaucracy. Bureaucracy is not only an inheritance, bureaucracy is also a sense of power by those who are able to wield it. So I'm keen for you, very briefly, if you could say, where you think we can quickly bring it in to at least make some sort of difference that in the long term one hopes will expand.
Excellent question, Dr. Sarkar. I will try to give you a brief answer to the modesty of my understanding. I believe this additional courses, humanities, business and such, that would sensitize the physician. Look, back home in India, an 18-year-old or 17-year-old girl or a boy, they get into medical school. But the rest of the developed world, they require a minimum of 4-year bachelor's degree before applying into medical school. So we need to expand our current BSc from 3 years to 4 years and pack it up with relevant subjects, such as you and Dr. Aisha and Dr. Rishita and Dr. Nilanjan, sorry, the Indika were talking about. So if that happens, there would be some level of maturity, at least 2021. Then they join a 4-year program, and then they expand also into extending the residency program. As it is in the United Kingdom, I'm sure, no one gets in to become a full-fledged doctor after MBBS. You have to do your residency, then you have to do your fellowship and the works, and take all kinds of exams. So I hope I've answered it. It's doing a BSc 4 years, preference 1 year fully loaded with the the humanities that talks about taking a good citizenship, civics, political science, social science, psychology, communication, listening skills, reasoning skills, how to negotiate. And one last thing, from a business point of view, one of the things that emphasized here is that if you're ethical, you'll make more money. No question about it. In the long run and in the short run, if you're ethical, you'll get a better reputation, you get more money. So why not make more money and be ethical at the same time?
Indika, sorry, you were going to speak.
Thank you very much. Few areas. One thing is, yes, I also agree with Dr. Reddy that education alone is not enough, but that's also very important. The capacity building is a very important area, because once you have developed the capacity of individuals or decision makers, and that would ultimately lead into the health-seeking behaviors and changes. But again, I fully agree that it's not only education. You need to make an overall change in the overall ethos or the culture, the health-seeking behavior and the health literacy. This overall culture in the society is very important, because that is what would lead to more sustainable long-term changes. And also because it should be the people who are the change agents. They need to take things into their hands and take the control into their hands, and they have to make the change. So that's very important. Again, I would like to make a few examples from Sri Lanka. You might have heard maybe about 2 years ago. Sri Lanka, like many other South Asian countries, there is very deep-rooted corruption, inefficiency, malpractices, so on and so forth. So people in the country, they took to the roads about 2 years ago, and they actually managed to change the government. And then just few weeks ago, again, as maybe as a continuation, people were basically voting with anti-corruption sentiments. And one thing I have seen is females have taken a lead role there in that change. So that's what I mean, that there needs to be an overall change in the overall ethos, in the environment, how you think, so the sentiments. So that would lead to a big change. That would lead to a big change, because otherwise what would happen is, in our countries, however much education you give, we have limited opportunities. So in these limited opportunities and in this competition, sometimes the ideal results, it may be difficult to achieve. More so because we have the limited resources that are available. So I think creating this overall culture related to health and the patient-centeredness is very, very important. So that's something that I would like to propose. And regarding medical education, I believe integration with the humanities is very, very important, because nowadays content you can teach easily. It's in the fingertips, and however much you content you teach, that would be forgotten in maybe a few months' time, or maybe the guidelines would change. So I strongly believe that medical education should strongly focus on the empathy and communication, professionalism, patient-centeredness. We should focus a lot more on those areas, because the knowledge you can gain and content you can give with the current situation. So that's what I am basically trying to say. So that's one area when it comes to medical education. That is one area that we need to focus a lot on patient-centeredness, on communication skills, so on and so forth. Thank you. Over.
Thank you very much, Professor Reddy. I'm just going to come back to give you a chance to speak, but I just wanted to say one thing, ask one thing actually to Indika, which was that, when you were in your initial remarks, when you were talking about the fact of high rate percentage of women's education, female education, also the way in which they reach out at the rural, in villages, etc. Women, public health workers, etc. You did make an exception, which was quite interesting to note, about sexual health issues and abortion and etc. The question that came to my mind, and it came to my mind also because I had been reading some of the stuff that Rishita has published, is in the context of India, is that while acknowledging all the good things that Sri Lanka has, which is the product of decades and decades of free education, and Sri Lanka in South Asia was one of the first countries to actually introduce it and has sustained it to its credit. What is your understanding of what kind of dynamics there is in situations where a male doctor and a female patient do have to interact for whatever reason? Right? And in terms of what we are discussing today, because this is very closely related to the whole idea of what women patients are able to say and speak clearly. And if there is a general cultural reticence to talk about sexual health issues and abortion, even amongst women themselves, then what is the dynamic when they're both, a male and a female are involved, and the male is the doctor? I was just curious to hear what your view is in the context of Sri Lanka.
Okay, it's not an uncommon situation where a female being encountered by a male doctor, because anyway the females are very much highly exposed to the health system. Because of the nature of the public how the public health system is arranged, and they are very much exposed to or maybe given opportunities related to reproductive health, not sexual health per se, but if you take the overall reproductive health from the time period they get married, and since then they are given advisors and also the access to the healthcare. With that increased access to the reproductive health facilities, it's not an uncommon thing where a female being examined by a male doctor. That happens because about 45% of the doctors in the country are males. So it can happen. So generally there are ethical guidelines that are there, like there need to be a chaperone, so on and so forth. And usually unethical behaviors are very, very rare, even though there has been some. Usually unethical behaviors are very rare, and there are certain guidelines. And also when it comes to the reproductive behavior, there is not much of reluctance in coming up with the problems. Even with a male doctor, generally our patients would come up with their problems. For example, maybe the menstrual health or other reproductive health problem. They will provide details and they would allow examination. So that is there. That is basically accepted. Maybe apart from maybe a very few due to cultural and maybe religious reasons, generally it's accepted and generally tolerated. And that's not only about medical care, but when it comes to even medical education, when the medical students, when they are studying in a maybe a gynecology or obstetric hospital, they need to do the gynecological examination and other intimate examination. Generally patients allow them, and they think that's something meritorious. They are helping the next generation of doctors. So what I'm trying to say is generally tolerated. It's tolerated.
Yeah. Could I just butt in and say, to correct, I should have been more clear. I wasn't in any way suggesting unethical behavior between a male doctor and a female patient. What I was talking about was attitudes of paternalism. So let's say a woman patient comes to a male doctor with any issue, let's say breast cancer. Okay, let's take her, which is not a sexual health issue, but is an issue which involves physical examination, etc. The question I was trying to ask you in the context of today's discussion was, and let's say there is a chaperone. The chaperone is likely to be either a medically appointed chaperone, which actually exists over here as well in the NHS over here, but also it could be the husband or whoever, or another woman, family member. But my question is, what is the medical dynamic? Would the doctor examine the patient and speak to the male, accompanying male, or would the doctor treat the woman patient as a sovereign entity in and of herself and tell her, this is what is happening, this is what you need to do, etc., in the way that the doctor would speak had it been a male patient with prostate cancer, let's say? That was the question I was asking you, not about unethical behavior. That wasn't what I was suggesting at all.
Yeah. I would say that is a norm. That's a norm than the exception. Like the treating the patients like someone who can take independent decisions and guiding the patient to the correct places and advising them in a empathic way. So that is happening. I mean, that generally that has been the way the doctors have been trained also, and that's a practice. And there are very clear guidelines on how to advise patients and also how to guide them to the self-examination or maybe the mammogram or other facilities. So generally there is no reluctance, there's no barrier. So because one reason may be that high literacy rate of the females, because of that the understanding is better. So that wouldn't put the doctor also into an uncomfortable situation or maybe a compromising situation where doctor may be reluctant to come out with more intimate information or detail. That is not there, partly because the females are very much exposed to the reproductive health concept and the facilities, and also the literacy rate. I think that would be the case, and in my experience, that is the norm than the exception.
Okay, great. Professor Reddy, you wanted to say something. Rishta, I'll come back to you. Professor Reddy, you wanted to say something, and I promised that I would come back.
But because I appreciate this, yes, of course. I was talking about the teaching medical ethics at medical colleges, following Dr. Indika's comments. I would like to add that medical ethics should be taught by a qualified ethician. I'm somehow biased about it because I've spent years and years studying it and I still don't understand it fully. And I'm still struggling with questions of my own, So when I was teaching medical ethics in India, it's become fashionable and just about every medical school has got an ethician. And, I call them well-meaning physicians. Some of them were very good friends of mine. But the well-meaning physicians, but they were teaching from the seat of their pants, literally. I asked them, what textbook do you follow? He said, no, I follow Google. And it's so easy, because we look at the guidelines, international guidelines, ICEP guidelines, or GCP or whatever, and they start teaching it. There is no textbook that they follow. And another question is, I try to introduce a textbook. It took me a monumental effort to get it passed through there is some kind of a government guy who sits there and he signs off with his green ink. And he never did. And I couldn't get the book, introduced into the college. So then I copied my own book and then I gave them the copies to the students. And that's how we were able to complete the course. So qualified ethicians must teach it. And it is because ethics is taught by somebody who doesn't understand, it is tantamount to allowing a barber to do an appendectomy. He may do it successfully, but I sure wouldn't like him to do that on me. So.
Great. Thank you very much. Rishita, I'm going to come back to you, but before that, I'm going to give Aisha a chance to answer Rishita's question, which is, Aisha, what do you see ahead as a positive way forward to address issues in the way that Indika and Professor Reddy, they've suggested a few things?
Yeah, actually,
in the context of Pakistan, I should say. Yes.
Yes. Yes, of course. My observation is that the young doctors are learning the professionalism and the medical ethics from their seniors, which is a role model method of learning the professionalism and the values and norms of the profession. So, which I think is flawed in itself, because when the practice of the seniors is less ethical, it is inculcated into the young doctors also. Like in the context of Pakistan, like I was conducting my research, my field research in Lahore, and there was a doctor, a young a medical doctor who was a house officer. He mentioned that his medical officer, who is actually the senior to some of the house officers, and the house officers are actually reporting to that medical officer. He mentioned in that interview that their senior came one day and asked them, let me say it in Urdu and Hindi, and then I will translate it into English. He said that how आज कितने बाबे लुढ़काए तुम लोगों ने. So, like, how many old men you have killed, old patients you have killed today. So, this is some kind of ridiculing the patients, and it indicates that they are like house officers are doing experiments with the old and poor patients in the public hospital. So, I mean to say that if the senior doctors have such attitudes, it is definitely going to affect the young doctors, which are indirectly learning the professional ethics of medical profession. So I think we need to address that along with the medical education, with the humanities, some of the humanities related courses, and some social sciences. So this is also something which needs attention. And is Rishita, is it the answer to your question? All right, and I have a question that I want to address to Rishita. Actually, I was thinking, can I ask Nilanjan? Would you allow me? Okay, so actually, I was thinking, what are actually the barriers of the medical encounter when the patient is going for abortion to a medical doctor, and there is one-to-one interaction, like the interaction between the doctor and the patient? And what are the barriers in that particular situation regarding the abortion? Like the patient is asking for abortion, what the doctor is saying to the patient, is it something an unequal distribution of power, which is central to the paternalism? Can you please elaborate on that? Thank you.
Nilanjan, is that okay? It actually ties in really well. Thank you for that question. I think it ties in really well to what I was going to say earlier as well. So I'll start with the encounter, right? Look, fundamentally, this encounter is embroiled in power and an inequitable power relation. You are seeking care for something that in many ways, even if it is legal, even if it is a medical procedure, is deeply stigmatized. You are transgressing, right? Either you're transgressing in that an abortion itself is often socially seen as a transgression. Maybe you are not married, right? If you're not married, there's an additional layer of how you need to be, that you're breaking a lot of rules. The abortion is not just that you're having an abortion. The abortion is proof that you've had premarital sexual activity, right? So it carries much more than just, I need a procedure. And then you have other things, like if you already, and look, a lot of my interlocutors already had 2 children. If you've got a very strong fertility norm of you should have 2 children, and that is the right behavior, any more than that, like you should have been sterilized. You should have been more responsible with your fertility. Why weren't you using contraception? Right? Like a lot of the doctors, not just the doctors, and very similar to what Professor Karunathilake was saying, like even in India, we've got community healthcare workers who are women from the village, right? Whose job it is to talk to you about contraception. We have the eligible couples register as well, where you should be accompanied when you're pregnant, you should be accompanied to the healthcare, to hospital. Right. So there are also within these encounters ideas and social norms of what constitutes correct behavior. right? Of the responsible way to be in this space. How are you responsible with your reproduction? And abortion, or even asking for contraception, or not being sterilized, are all markers of transgressing in some way, of moving, of not keeping with that social norm, right? Of how you are expected to be. And so here's where you have then the doctor in this position of power, even, reinforcing that norm. So a lot of them would say, I went to the doctor, I went to the public health center and I said, my period's not coming. And they'd, make me do a urine pregnancy test. And then they'd say, you've already got 2 children. You should know better. Why weren't you sterilized? I told you then, when you had your last child, you should have been sterilized and you weren't. And they all talk about how poorly they had been spoken to, how ashamed they were. Right? And then you've got this additional layer of secrecy that they're trying to keep, because the more people that are involved, the more people that know that you have a pregnancy, 1, and then 2, so it's an unsanctioned pregnancy, right? And then 2, that you want an abortion. So there's 2 layers that you're grappling with here. The more you try to keep it secret, you don't know, can I trust this doctor who is in my primary healthcare center? And if I'm going with the Aisha worker, the community healthcare worker, who is also from my village, how many people are going to know? How many people are going to get involved in this decision making, right? And so the more fraught this encounter becomes, the more constrained you are in or needing to deal with more and more obstacles. So the majority of the women that I'd spoken to about their abortions, who self-managed their abortions, between confirming their pregnancy and using medical abortion pills procured through a pharmacy, had about 3 weeks, right? That's 3 weeks that you're still in control. Those who went through a clinic and then had to deal with multiple clinic encounters, some of them with delays, like needing to then go to a district hospital. And as you may know, like going to a district hospital can take hours, right? That's hours of childcare, that's hours of lost wages, that's hours of needing to like explain, where are you going if you're keeping it secret, right? The longest delay I saw was 13 weeks. Right, from the point of recognizing to actually accessing an abortion. Now that's a huge, that's a lot of burden for somebody to carry, right? And a lot of that comes back to this fear of a medical encounter, and a lot of it also predicated on their previous experiences, right? Like, I didn't do something that you told me to do. And this is where I think while education is important, and what is the content of that education is important for us to think about in medical education, I also think it's important for us to interrogate what are the norms that are being reinforced and reproduced through the clinic, through the doctor, and through this interaction between the physician and the patient. Because otherwise, it's really there that we're seeing this paternalism reproduce, right? Because you need to be behaving in certain ways. It's a form of disciplining that occurs.
May I just say one thing before we go around the table once more, is that this, Rishita, is to you, and I appreciate very much that your work is focused on abortion and therefore this. But what is very prominent in your work and what you have just said is also very specific to that particular kind of encounter where, there is the moral element. But what I was curious to ask you was, because I speak entirely from a position of ignorance, is more widely speaking, suppose this had not been abortion, suppose it had been something like cancer.
Diabetes.
Yeah, or diabetes. Yeah, let's go with diabetes. Okay. So would the doctor still say, the male doctor still say, you should have been doing this? Like people would say to someone who's overweight, oh, you should have controlled your weight. You should not be eating so much.
Yeah.
And
definitely. It's the same, right? There are certain ways for you to behave, right? You should be taking, you should be walking, you should be doing exercise, you should be, and like, let's put that in context, right? How are we saying that to someone who has 3 children to look after, lives in a joint family, has, informal work, is, has parents-in-law living with them, that they've got to do a lot of that care work for? So what time for exercise? What control over food do you have, right? So yes, it still becomes while it may function in different ways, fundamentally it is still a creation, I think, a creation of, there are certain ways you should be functioning, right? And that you're not doing your bit.
That there's a normative element to
Yes.
it that you are violating, and therefore you are somehow responsible for.
Yeah, and I do think that sort of comes through, and even with cancer, like some of my colleagues do a lot of work on cancer, and look at cancer hospitals. And again, it's things like where people might have really strong ideas about, whether, like, what cancer medication means in their lives, right? Like how it's situated and shifts their interaction with their body, with their self, how it shifts, what that means for, am I still a parent? How do I parent? How do I care for people, right? That fundamentally there are ideas of what is the right way to behave. Right? And this is where I think this encounter can be so fraught. And exactly, yes, what are the ethics of this encounter? Like, yes, are we predicating this on there should be a good outcome, right? That the health indicators should show that this was a good outcome. But what the health indicator shows, or what our ultimate measurements are, may not be in keeping with what is a good outcome for that individual, right? Even if it is irrational for them, is that not what we should be considering? And this is why I come back to this question of, like, what does it mean to care, right? How have we conceptualized this? Not just in provision of medicine, provision of advice, provision of information. It's also, how is someone receiving this? I think, and that's where this, and I think that points to your question, Dr. Jalil, of like, what is the encounter here?
Can I just ask everyone, because I'm very keen to know, and I'm also conscious of time, that what happens if the ailment, and the patient is a woman, and the ailment is genetic? So you can't then say you should have eaten more or done exercise. So suppose it is, I don't know, multiple sclerosis, right? Does research show that it is still the patient's fault, that there is still this paternalism and this condescension almost in the way that doctors will approach paternalism, how it is imbued in the way in which they speak to patients? Anyone wants to start on that? Rishta, you're giving a very knowing smile.
I've spoken. I'll let others speak first.
Okay. Let me say quickly, in the sense, I think in the context of a doctor-patient relationship, certain conversations, depending on the context and the situations that normally take place, and I don't see anything wrong, a physician chiding a patient, or if there's a lot of history between the patient and the doctor, and saying that, look, if you keep on smoking, man, you're going to get cancer. But it shouldn't prevent the doctor from prescribing appropriately. At the end of the day, caring of the patient is paramount. And after all the doctor is doing is prescribing a medicine and giving some advice. The guy who really takes it on the other end is the patient. If the patient doesn't take the medicine, if he dies of his own negligence, then nobody is to blame, I should like to think. And may I ask a question to Dr. Rishita?
Please do. If I could only just say that when it comes to doctors chiding patients, I think enough male patients get chided as well. So I think we can agree on that, because that really is that really is the cross that patients carry. But yes, please ask your question.
Right. And speaking about what you mentioned about, like, how would a male patient treat if there's a female? In our country in here, whether she comes alone or with a chaperone, the doctor always has to have another female member before talking to the patient. So there is no way a male doctor would stay in a cubicle all alone by himself. These are the regulations. Even if you are the most virtuous kind of a guy, you have to abide by these rules. That's the way it works. So my question to Dr. Rishit, a very fascinating take on abortions and all that. So real and so true what you say. But I have a question, which is, if abortions are done on demand, and for whatever reasons, and I'm not here to judge, let's say the young person comes over and the doctor says, look, if you are under 26 months, is the weeks, is that the rule norm, 22 or whatever? I'm willing to do it. Sorry, you're muted. I'm sorry, I can't hear you.
Sorry, so it's up to 20 weeks with one doctor's permission in India, and then between 20 to 24 weeks, it's two doctors, and after that, you have a medical board.
Oh, okay. Let us say there is somebody, under 20 weeks, and this is a second abortion, and she gets it done. Are we desensitizing that young child about what about the value of human life? Meaning, let us say she does it for efficiency reasons, for whatever reasons, for financial reasons, but certainly not for the welfare of the child. I mean, she's gone because the mom has decided, I can't take care of you. Now, let's say 60 years down the road, our own parents become invalid and they're in the hospital. Would you not think, she would say the same, I cannot deal with you. Now I'm going to put you on a canoe and then leave you down in Alaska and then
I think,
goodbye.
No, I think that's a really, for me and my work, I think that's a really false setup, right? Because I don't think fundamentally having an abortion is about whether you care for people, right? That's not, we don't have that in the literature. We don't have that in people's narratives of why they have abortions, right? It's not that you don't care for your family. Actually, the vast majority of people who have abortions are people who already have children, right? That's statistically, that is how it is, right? And so this idea that I may not care for my parents in the future, I think is a false setup.
No, it is not. Sorry.
I mean, that's not bearing out. We don't have that. We don't see that bearing out in any way. These are people who live in families, who care for their families, who live in communities and build their communities. The second thing I will say is that I don't think we need to frame this in the idea of like value for life, right? Because often if you ask, why are people having abortions, right? People are having abortions because of, like, again, in the vast majority, the overriding explanation for why people wanted an abortion in my own study, and this bears out in the literature more broadly, is I cannot care for the children that I have. Right? I have children already. I can't feed them. I can't clothe them. I can't send them to school. I can't care for my mother-in-law who is sick and who I have care responsibilities for on top of the children that I have, right? So I don't think this idea of abortion is somehow indicative of your ability to care or future ability to care. It doesn't bear out, right? It's the most common procedure in the world. Like 1 in 3 women will at some point have an abortion. So unless we're also then suggesting that these people don't care for their families, don't care for their parents, I think, a real disconnect from what actually happens. Because I think it's a thought experiment, right? But it's not borne out in the evidence.
I understand. I mean, well said. I appreciate the response. But I'm hearing, I don't have evidence or data to back this up. For the first time, I'm hearing in India, the place where I come from, Hyderabad, to be particular, there are lots and lots of old people are being abandoned, and you read about them in the newspaper. And this was something which we never heard of when I was growing up, but now it's happening more than often. Basically, literally, the mom and dad, they were asked to leave the place, and the TV guys come and take the pictures, and the whole thing runs for 10 days, and they've forgotten. So I just wondered, whether are we becoming, one more thing, Rishita.
Yeah, if you wouldn't mind, Professor Reddy, we do have 3 minutes. So if you could be brief.
Well, okay. Now when you look at the poor people, when you get used to seeing them day in and day out, you step over them and you don't feel anything. It happened to me. I myself did it when I was in India. I would jump the line and do all that without a care. But later on, after living here in a different climate, a different culture, I'm becoming more, and I feel guilty for doing it. So is there a sense of desensitization that goes on when little kids keep on playing with guns? They really end up using it indiscriminately when they grow up. By end of my question. So.
Sure. Thank you very much. If you wouldn't mind, this is a discussion to be taken, on another platform, because I'm not quite sure that there is a direct correlation between these, even from my generalist perspective. But I am going to ask Indika to say something that he had said he was going to say, and then we will go ahead, Indika.
Yeah. Thank you. Yeah. I would say, I mean, even this question, if someone comes with diabetes or maybe multiple sclerosis, still is there a possibility of paternalism? I would say yes. Yeah, but it may be an issue with the overall the society or the societal attitudes and behaviors. I mean, in our countries, one example is certain behaviors are considered as taboos. So that's there in the larger society. So that would maybe, I mean, maybe touch upon the health professions also, maybe even unknowingly. That possibility is there in many instances. And in Sri Lanka is mainly a Buddhist country, and there's the belief of the karma, like that it can, I mean, even if you haven't done during this birth, it might have happened during the previous birth. So that possibility is also there. So sometimes putting the reasoning it out on the impact of karma. So that happens in the larger society. So those possibilities are there. So, I mean, it is may not be an issue with the medical profession, but the larger society, the cultural beliefs, how they look at the diseases and the behaviors, these things are there. And it can happen due to sexual areas or non-sexual. For example, I mean, teenage pregnancies are very common in Sri Lanka. So in a larger society, it comes as a taboo, not common in all the areas, but if you go into the, say, underprivileged agricultural areas in the far away from Colombo, that can happen. So the society, even school teachers, may look down upon these kids and consider this a taboo. So that can touch upon even the healthcare workers. That possibility is there. So I would say it's an overall social justice and the overall ethos that matters. Thank you.
Thank you very much. I'm afraid we have to stop this. It has been wonderful, and it has been extremely educative and typically unexpectedly animated. But I want to thank all of you individually and collectively for taking the time to participate in this, because I have been doing this for many, many years now, but I have always said that if there's any one thing that is good that came out of the pandemic, it is that we all became technologically more savvy, and that Zoom entered our lives and enabled us to do a lot of things. But it is equally true that we can't do these events if each of you and all of you do not give so generously of your time, your expertise, and your knowledge, which in many instances is the outcome of years and years of very hard research and reflection and thought. So thank you everyone very much, very sincerely. Aisha Jalil, Indika Karunathilake, Deen Dayal Reddy, and Rishita Nandagiri. And thank you also to our audience members.